Hello, everyone. We are very pleased to have you join us today. I'm Kobe Claude Adoso. I'm delighted to present you our speaker today, Dr. Rona Orentlicher. Dr. Orentlicher is an assistant professor of radiology at Albert Einstein College of Medicine. She obtained her doctorate of medicine and completed her residency as well at Sunnysdale State Medical Center. She has done 2 fellowships in pediatric radiology and in adult body imaging. She has a certificate in bioethics and medical humanities. Dr. Orentlicher is currently working as an attending radiologist at Montefiore Medical Center, and today she will talk to us about the radiological evaluation of non-accidental trauma. Thank you, Dr. Orentlicher, for joining us today.
Thank you so much. Thank you all for giving me the opportunity to speak about such an important topic. So the topic today is the radiological evaluation of non-accidental trauma. Just to give a little bit of a backstory, a little bit of some statistics before we get started. In the US, in 2017, approximately 5 children died every day as a result of child abuse. And a report of child abuse is made every 10 seconds. Physicians and allied professionals are mandated by law in the United States to report suspected abuse within 48 hours to Children's Protective Services. These are statistics in the United States, but we all know that this is a global issue. And we, as radiologists and clinicians, we really need to know exactly what to look for. So the term was actually initially coined by C. Henry Kemp. He was a pediatrician, and he was the first in the medical community to identify and recognize child abuse. And for it, he received a nomination for a Nobel Prize in Medicine. He used the term battered child syndrome, and the terminology was any child who received non-accidental physical injury or injuries as a result of acts or omissions on the part of his or her parent or guardian. We have since evolved, the term has evolved since then. And you can see from his battered child syndrome, he refers to physical abuse only, but we all know that it really encompasses much more than just physical abuse. Neglect is seen in 75% of patients. Physical abuse, there's sexual abuse, there's deprivation or psychological abuse, and there's medical neglect. You can see that the percentages add up to more than 100% because we all know that there's often more than one abuse going on in the battered child. So who are the perpetrators that we're talking about here? They did a study in 2017 where they broke it all down. And the most important number here is this 91.6%. They broke it down into parents and non-parents, and you could see that various iterations of the parents, either mother, father, mother by herself, father, or non-parent thrown in there, make up 91.6% of the perpetrators. So we're really talking about somebody who's very close to the child. Non-parents are not excluded. They are also definitely 13.5% were seen in this survey, and they range from foster parent to legal guardians and partners and other relatives. But the most important percentage, I think, is this one to remember, that it really is somebody who's very close to the child, often the person who is bringing the child to the emergency room. What about the age of the child? What's important is that you can see that the children who are under the age of 1 make up 25% of the victims. And if you looked from a newborn to the age of 5, it's about 70% of the cases. So the vast majority of these cases and the things that I'm going to show you are really geared much more towards very young children who are clearly the most vulnerable. And again, of course, it involves older age kids too, but to a much less degree. So the first thing that we need to discuss when it comes to battered child syndrome is the history. As I said before, 91% of the perpetrators are some type of a parent or combination of parents, and they're the ones that are going to bring the child to the emergency room. And history is really, really, really important. Most importantly, discrepancy of history between the history and the injury. So for instance, is there a reluctance to provide the history? Is there an unusual reason that they came to the hospital in the first place? Is there a delayed hospital visit after the injury? All those things should really be a red flag and make the clinician or the radiologist sort of stop and think, is this truly a benign fracture or is something else going on? The other possibility is hospital shopping. Have they been to multiple hospitals? Has the child been here multiple times or a sibling been in the emergency room multiple times? So these are all things that really have to be taken into account. History is key. There was this very interesting retrospective study done of accidental and non-accidental injuries in a level 1 trauma center in Dallas. They took multiple separate studies, and what they did was they looked at household falls, and they looked at what happened to these kids when they fell from heights up to 5 feet. So just to give a little bit of context, 5 feet would be approximately the level of a changing table. So any falls from a changing table, from a bed, from a chair, from a sofa, anything up to 5 feet, they looked at what type of fractures were sustained amongst these 529 falls. And of that fairly large number, there were only 4 skull fractures, 4 clavicle fractures, and 1 humeral fracture. So it was a 1.7% incidence of fractures in all of these falls. And there were no neurologic injuries at all. So the conclusion was that common falls rarely are associated with fractures, whereas non-accidental trauma usually has a much higher severity of injury. So what's important here to remember is that when the perpetrator, when the abuser brings the child to the emergency room, and a very large, vast number of times, the history that they will give is, I turned my back, the baby fell off the changing table. I had her on the bed, I got off the bed, and she toppled over onto the floor. You can see from this study that it's highly, highly unlikely that a baby is going to show up with a significant fracture if they fell off the bed, if they fell off the changing table. So it's important to keep that in mind when you look at the history. And again, history is so important. So now let's look at the frequency of skeletal trauma, and this is in order of frequency. Extremities are the most popular, the most common. Then you have skull fractures, rib fractures, clavicle, pelvic, and the least common is going to be the spine. So what we're going to do is we're going to start with the physical findings, and we're going to break it down into high specificity, moderate specificity, and low specificity of injury. By high specificity, I mean these are the fractures that are highly specific for child abuse. If you see these type of fractures, a bell should go off in your head. There's the classic metaphyseal fracture or metaphyseal lesion, posterior rib fractures, scapular fractures, sternal fractures, and spinous process fractures. So if you see these fractures, you want to evaluate the history very clearly, and you want to see if what's going on. And why are these so highly specific for child abuse? A lot of these injuries are caused by this rapid acceleration deceleration type injury. You could see from the age of the child that we're talking about very young children here. Often these are children that aren't even walking yet. So what happens is the abuser will lift up the child, hold the child either under the arms, in the chest area, and shake the child back and forth. And with that rapid acceleration, deceleration, you're seeing a lot of these very specific type fractures. And we're going to go over all of them. So the classic metaphyseal fracture, or CML, is highly specific for abuse. And what you're looking for is you're looking for these corner fractures or bucket handle fractures, generally involving the metaphysis, most commonly in the lower extremities, but you could see them in the upper extremities as well. But you're looking around the knees and the ankles, and I'm going to show you some examples of each. And again, it's caused by this acceleration, deceleration, and this shearing forces that occur perpendicular to the long axis of the bone. And what it does is it basically shears off the metaphysis completely. There are different degrees. If only a portion is sheared off, we call it a corner fracture, but the bucket handle fracture is the entire metaphysis is sheared off. And this is just a nice drawing. This is the around the knee. This is the epiphysis. Here's the diaphysis and the metaphysis. This is a young child where it hasn't fully ossified yet. This is the corner. This is the the bucket handle fracture. It's a complete shearing off of the metaphysis. If only a portion of it is sheared off, it's called the corner fracture. And you can see youngest children are the most vulnerable when it comes to these types of fractures. It's called a bucket handle because it looks like the handle of a bucket upside down. And this is a classic example of a bucket handle fracture. This is the ankle in a very young child. You can see that there's the epiphyses haven't ossified yet. You could see that the metaphysis is just basically sheared right off. This patient has a little bit of periosteal reaction as well. You don't want to miss these. This is a corner fracture. This one you could easily miss. You could go right by this one. They're very subtle, and you have to really keep your eyes open and make sure that you look for them. This is a bucket handle fracture with a little periosteal reaction. This is a tiny little corner fracture. If you didn't have a good lateral projection, you would miss it completely. Here is a very subtle bucket handle fracture on the frontal view, and here it is on the lateral view. Very easy to miss. They can be very subtle. Small corner fractures along the distal tibia are best seen on the lateral projection. This is bilateral bucket handle fractures with extensive callus and periosteal reaction, and corner fractures in the femurs as well with periosteal reaction. How about rib fractures? Rib fractures in infants are very unusual outside the setting of abuse. And why do they occur? So again, these are very small children. A lot of them are infants. The abuser will pick them up. By the chest, the thumb will be on the anterior portion of the chest. So with pressure, you could see that there would be an anterior rib fracture. As they're squeezing and compressing, they will fracture the lateral rib, and behind and posteriorly, which is highly specific for child abuse, it fractures because it goes right up against the very hard vertebra and the transverse process of the vertebra in particular. And so you could see fractures right at that site. So it's that chest compression with violent shaking. Posterior rib fractures are very specific. And again, very rare mechanism in accidental trauma. They're seen in 35 to 60% of abused infants. So you really want to look at them. If you're not sure that there's something, what you could do is you could bring the patient back after several days, because once callus formation starts, it's much easier to see. Here is an example of a very young infant. There's healing fractures of the lateral ribs, and there are multiple posterior rib fractures with callus. Here's one, here's another. I strongly suspect that there are fractures here as well, because you can see that they're much thicker than in other places, and then there is most likely one here as well. Multiple posterior rib fractures, lateral fractures in a very young child. This was child abuse. And they could be very subtle. You're going to look for symmetry, okay? So here's a nice normal looking rib, and this one is clearly more bulky. So they're bilateral posterior rib fractures that you could easily miss if you don't look for them. This was an unfortunate child, only a few months old. She came in unresponsive. She had a massive cerebral hemorrhage, and she was found to have multiple healing rib fractures. These were lateral rib fractures. And these are just acute lateral rib fractures. This is a cadaver where you could see callus formation in the posterior rib right up against the spinous process. So you could see how this could have been fractured. Scapular fractures. When was the last time you saw a scapular fracture? They're really unusual. This abuser lifted up the child, grabbed the child under the arms, and with shaking and squeezing caused the fracture. Here's another scapular fracture in an abused child. Sternal fractures. Classically, right here, classically, they are caused by punching or kicking in the chest, or they may be caused by some type of blunt trauma with a hard object. They are often seen in all ages of kids. History is extremely important. If this was a 17-year-old football player, who wasn't wearing his football gear and he was tackled, in theory, they could get a sternal fracture. But if you're going to see it in a 1-year-old, most likely he was punched or kicked or hit with an object. What about moderately specific? So these are fractures that are not classic for child abuse, but should make you sort of stop and think. And most importantly, moderate becomes high if there's an absence or an inconsistent history that goes along with it. So you're going to look for fractures of different ages. You're going to look for multiple fractures, especially if they're bilateral. Hand and foot fractures, again, they're moderately specific. We hear a lot about, I've seen a lot of kids who, are crawling and they get their hand caught in a door and they show up with a fracture of the tip of their finger. It happens. This is why they're not highly specific, but you need a good story to go along with it. Vertebral body fractures and complex skull fracture. If the patient was in a car accident, then you could explain the complex skull fracture. If the story is they fell off the changing table, then you know that something is suspicious. These are multiple fractures, different ages. This one is subacute in the arm, and these are acute fractures. This is healing fractures in the metacarpals, and this child was hit with a blunt object. How about spine fractures? Without good accidental explanation, especially in infants, it's suggestive of non-accidental trauma. It's the typical shaking with deflection and extension and compression. What happens is the classic location is going to be the thoracolumbar junction, because that's where you hyperflex, and you're going to get compression fractures and superior end plate fractures. So you want to look at those specific locations. Compression fracture right at that thoracolumbar junction. You have to look. It's really hard to see sometimes, especially in little kids. But if you look at the vertebral body heights, they are basically symmetric. They all look about the same until you get to here. This one also looks a little denser, but it definitely has looks like it's squashed compared to the one above it. So there's diminished height. This one looks normal. This one also looks like it's diminished height. And you could see compression fractures. I think there's one here as well. They can be very subtle, so look carefully and look at that thoracolumbar junction. This obviously is a terrible cervical spine in a child where you had that the flexion extension, and this child did not survive. How about skull fractures? Skull fractures are common, and again, not specific for non-accidental trauma, but they are seen in up to 40% of cases of abuse-related homicides in infants. They are often the result of contact injury. The child is thrown against a wall. The child is hit with an object. There are no good studies, and they've tried to study different fracture types to see if they're at all suggestive of abuse, but there really is nothing that clearly specifies child abuse. So what they look for are multiple fractures, fractures that cross the suture lines, bilateral fractures, and again, you always want to look for that inconsistent history. This is an acute fracture, a single fracture, not specific for child abuse. This one, on the other hand, has multiple fractures. Here, history is very important. This is a blunt injury at the top of the head with a bat. And this had a very inconsistent history. This was child abuse. Here's a small subdural hematoma with a very subtle skull fracture. This is a severe depressed comminuted skull fracture. You could see air in the brain, and you could see a large amount of soft tissue swelling. This was blunt trauma. How about CNS injuries? They are the leading cause of fatalities in child abuse. The majority do not have fractures, and that violent shaking phenomenon plays a major role. They get subdural and subarachnoid bleeds, which are the most common, but not specific for child abuse. And it's a result of the shearing of or direct blow to the bridging veins, the shaking back and forth, acceleration, deceleration that severs the bridging veins and cause subdural and subarachnoid bleeds. How about within the brain parenchyma proper? So there are three different types of patterns that you see with child abuse. The shearing and diffuse axonal injury from the shaking forces. So you'll get small hemorrhagic subcortical white matter bleeds. You can get a contusion either from a direct blow or a contra coup injury, where there'll be a focal bleed. Or you can get cerebral edema if there's any type of anoxia or hypoxia from strangulation, suffocation, or post-traumatic. So those are the three patterns that you will see. Here's a case of cerebral contusion with a fracture. There's a subdural hygroma, there's an old bleed, and there's significant soft tissue swelling. This is a mixed subdural hematoma, acute and chronic. There's significant cerebral edema and loss of gray-white differentiation. There's mass effect. There's an interhemispheric bleed, and this child was 8 months old. This is a 2-month-old. You have an interhemispheric extraaxial bleed, and you have a right occipital contusion. What about common but low specificity injuries? Clavicle fractures, long bone fractures, and linear skull fractures. We see these a lot. Kids can get clavicle fractures when they fall off their bike, right? We see long bone fractures all the time. They're very common. They're not indicative of child abuse in and of themselves. So what you have to do is you have to look at the history. If the history is inconsistent or absent, low becomes high. Long bone fractures are really common. We see them constantly, and especially spiral type fractures. In non-ambulatory infants, in small children who are not mobile, why would they get a spiral type fracture? It's unusual to get. I mean, in theory, they could get their leg caught in between the bars of a crib. In theory, they could, which is why it's low specificity. But it's unusual. And so in those small children, if they show up with a spiral fracture, you really have to sort of look a little bit more carefully. And what happens is it's this torsional force, and it's like a corkscrew or winding staircase. And it occurs when the abuser twists the leg or the arm as he's grabbing the child. In ambulatory children, we see spiral fractures a lot. Toddler fracture, which are fractures when kids are just starting to walk, are common. And that's not child abuse. So overall, not specific for child abuse. This is your classic spiral fracture. Here's another example of a spiral fracture. And this is a fracture that's in the process of healing. So another important element of child abuse, and really something that's important, I think, in radiology in general, is to understand how bones heal and what the timeline is for that healing, because it really plays a big role in child abuse. If the perpetrator, if the abuser comes to the ER and the kid has a fractured arm and says that it happened yesterday, and you do an X-ray and there's periosteal reaction or callus, you're going to question that's an inconsistent history. So understanding how bones heal and in what time frame is really important. So I just want to go over it briefly and so that you have a basic idea of how it works. And it's a complicated looking slide. So I want you to just really focus on the middle one here, the one in red. This is a timetable of X-ray changes that occur when a child fractures a bone. So really focus on this, which is really at its peak. And again, there's variability, right? Some kids heal quicker, some kids heal later. But try just to remember these and you'll be in good shape. So what happens when a child first fractures? And then what happens after that? So what the first thing that happens, they fracture, they have a lot of soft tissue swelling. Then the first, on day one after the fracture, they start you get resolution of the soft tissues. So that is going to peak at around 4 to 10 days. After that, you're going to start getting periosteal new bone at about 1 to 2 weeks. Then the fracture definition, you start to lose it, and that occurs at about 2 weeks, 2 to 3 weeks. You start getting callus around the same time, that 2 to 3 week period. And then it turns to hard callus in 3 to 6 weeks. And then it remodels, and it could take up to a year for it to remodel. Again, there's variability. Some kids heal right away or very quickly, and they're all done by 3 months. Some kids may take 2 years to heal. So remember this, and it will take you far. So this is an example. Here you have a kid who fractured. You're not seeing the fracture, but you are seeing a little bit of periosteal reaction. So I know that this fracture occurred about 7 to 14 days ago. And that's really important given when I have the history. Here's another example. So here you have more callus. You have the fracture, but the fracture definition you're starting to lose. So I know, putting those pieces together, that this is about 2 to 3 weeks old, this fracture. And how about this kid? So this was day 1, bad fracture of the humerus, lots of soft tissue swelling. By day 4, the fracture is still there, but you could see the soft tissue has really come down. At 7 days, you're getting the periosteal reaction beginning. At 2 weeks, the fracture line is much less defined, and you have callus, and that's at 2 weeks. And by 6 months, the kid looks great. I mean, there's a little bit of deformity. I think it's going to take a couple more months for the deformity to resolve, and it could be, on average, the peak is about a year. But you could see how things evolve. And if you have this information in your head, you could really help the ER clinician if they're trying to decide if something is going on here that doesn't seem right. So what do we do when we have a skeletal fracture and we're suspicious for child abuse? So we do skeletal surveys. The important thing about skeletal surveys is I think we have a tendency, especially with infants, we don't want to radiate them too much. So we have a tendency to take x-rays of the whole body, try to get as much of the kid on the x-ray as possible to avoid over-radiating. But it's really important to take each bone separately because you really don't want to miss anything. And as I said, they could be really subtle. These little corner fractures are really subtle. And if you take a whole body x-ray on a little kid, you may miss a little corner fracture in the tibia. So you avoid whole body film on infants. If there's any area that you're really concerned about, you want to make sure you get 2 views of any abnormality. That's typical in radiology in general. We use these in postmortem suspicious cases. It's very important. If you don't see anything, but you really are suspicious that there's something going on, you can consider doing a nuclear bone scan to clear up particular areas. And you can also bring the kid back after a couple of weeks, repeat the skeletal survey. And if there's periosteal reaction or callus, it will help you to see if there was a fracture there to begin with. So this is the skeletal survey. The ACR and the Society of Pediatric Radiology guidelines were revised in 2016. But basically we do frontal views of all the extremities, all the bones, the femurs, the tib fibs, the humeri, bilateral, of course, the forearms, the hands, and the feet. You want to do a frontal and lateral view of the chest. And right and left obliques are excellent in looking at the ribs. You want to make sure that you look at the thoracic spine through that, in that chest, in that frontal and lateral view. You want to get a frontal view of the abdomen and make sure it includes the lumbar spine and the pelvis. You'll get a lateral view of the lumbar spine. You'll see those compression fractures at the thoracolumbar junction, much better. You get a frontal and lateral C-spine and a frontal lateral of the skull. So this is your skeletal survey. Here's an example of, there was a question of whether there was some occult widening of these two left posterior ribs in a 1-month-old. The history was a little suspicious, but they really couldn't pinpoint anything. So what they did was they brought the kid back for a bone scan, and you had increased uptake right in that spot. And not only that, but there was increased uptake in the bilateral humeri. And when they took more closer x-rays, they saw that there were tiny little corner fractures in both of the humeri in a child who was abused. So what about non-accidental abdominal injuries? They're not as common, but they do account for 25% of all hospitalizations for abdominal trauma in kids who are under the age of 1. Hollow viscous and pancreas are the most common areas to look for. And compared with accidental trauma, they have a much higher rate of exploratory lap, 6 times higher rate of death. They often have head trauma and thoracic trauma to go along with it. And again, they have a common inconsistent history, which is this: fall from bed, fall down the stairs, couch. These are kids who are often under the age of 1. So, you know, as I said, unlikely to have these kind of injuries if you fell under 5 feet. CT scan with IV contrast is classically what we do. This is just a pretty example of why these areas are so vulnerable. So generally, abdominal injury from non-accidental trauma is usually they are kicked in the stomach, punched in the stomach, hit in the stomach with something. So you're talking about generally the midline is going to be the most vulnerable. Why? Because all these soft organs, like the duodenum, like the pancreas, like the liver, especially the left lobe of the liver, they're midline structures, and all these soft organs get pushed up against the very hard spine. So these are the ones that get hurt the most. The kidneys generally are spared. They're more posterior. They're protected by the liver. They're not hit against the spine. Same thing with the spleen. It tends to be protected because it's a little bit more posterior. Obviously, if you get hit on the side, your spleen is going to be vulnerable. But generally, the most common is sort of a midline hit, and the spine causes a lot of problems. Hollow viscous, they are often from blunt trauma. They get a perforation in the duodenum or the proximal jejunum. Again, those are the midline structures. You're going to look for free air. CT is your study of choice. And hematoma, especially of the duodenum, is the most common. CT, sometimes we had in the past done upper GIs, which can be helpful, but CT is really the way to go, or MRI. This is just an example of how important it is to give IV contrast, really, especially in kids who have like no abdominal fat. It's very hard to read. You don't know what's going on here, but with contrast, you could see that there's a duodenal hematoma. This is a child who came in with vomiting, marked gastric distension with contrast. The kid was vomiting because there was a duodenal hematoma. Here's a 36-month-old abused boy with jejunal perforation. He has free air, multiple places. He has small bowel thickening and free fluid. This is a child who presented with vomiting and gastric outlet obstruction from a very large duodenal hematoma. And you can imagine if they're kicked or punched or some type of blunt trauma, that nice soft duodenum gets smashed right up against this very hard. It's like being hit by a wall. Your vertebral body acts like the wall. This is free air, jejunal perforation, and fluid. This is an upper GI series. You see a filling defect in the proximal duodenum from a hematoma. The pancreas is seen in 17% of abused children who also have visceral injuries. If you take away motor vehicle accidents, 60% are attributed to abuse. And they present with basically pancreatitis. The classic findings and signs and symptoms of pancreatitis. They have vomiting, fever, abdominal pain, their amylase is elevated. You'll see peripancreatic fluid. The ER doc should always look at the skin to see if there's any kind of midline bruising. CT ultrasound is not as great, but CT is very good. And if you need more help, you go for the MRI or the MRCP for further assessment. Here's a fractured pancreas with a lot of peripancreatic fluid and fluid here in a child who was abused. This is a subtle pancreatic hematoma in the body of the pancreas. Liver, 60% of all hospitalizations with visceral injuries will also have liver injuries. It could either be blunt injury or that sudden deceleration. It's rare to see in infants, and lacerations are the most common findings, and they're often undetected. The left lobe is most common because it's the most midline structure. You want to look for subcapsular hematomas. They have tried to look at elevated LFTs in occult trauma, and to use it as a way of aging the injury. I don't know how successful they've really been. There have been some studies that look at the ALT and AST levels, and they tend to go up after 12 hours following the injury, and then they tend to go back to normal after 36 hours. So they feel like if this study felt that they can age it somewhat, but it's in the beginning stages of research. CT scan is your modality of choice. This is a very large liver laceration, and here again, multiple liver lacerations in a child. As I said, the spleen much less frequently injured than the liver, and I think it's because it's kind of given some protection by the stomach, and of course, if you get hit on that side, you have an increased risk. But midline, the spleen is generally protected. The ACR in 2017 came out with this appropriateness criteria for a lot of different scenarios in radiology. What they were trying to do is sort of give a universal guidelines for radiologists and clinicians to help them determine what would be the appropriate studies for each type of scenario. I think the goal was to try to minimize as much radiation as possible. And in children, we all know that that's really important, as well as in adults. So they looked at suspected physical abuse in a child, and they had these various scenarios that depended on the age of the child, how they presented, whether they had neurologic signs, thoracic, abdominal signs, and their social considerations as well. So just to give you an example, just a little taste of what these appropriateness criteria were like, they rated them on a scale of 1 to 9. 7, 8, and 9 were considered appropriate type of studies. 1, 2, and 3 were not appropriate. And 4, 5, and 6 kind of were somewhat in the middle and depended on other variables. So this is like one scenario. So there's suspected physical abuse. The child is under the age of 2. Their neurological or visceral injuries are not suspected. So what are you going to do? So this is basically a child, they suspect child abuse, but they don't have a lot of other clear injuries. What are you going to do? So you're going to start with a skeletal survey, and that gets a rating of 9. This is the amount of radiation. You know, it's relatively high, but this is where you want to begin. And after that, there are other things you could do. You could do MRI of the head, CT of the head, you could do a bone scan, but you're going to do that. That's not going to be your first line of study. You're going to use that as a problem solver. These were given 6, 5, 4. So basically it depends on what else is going on from your skeletal survey, and it takes you down this path. But essential imaging is going to be a skeletal survey, as opposed to this kid, where this kid has one or more of the following: has neurologic signs and symptoms, has apnea, complex skull fracture, other fractures, injuries highly suspicious for child abuse. So what are you going to do in this case? Again, you're going to start with your skeletal survey. You get a 9 for that. He has neurologic symptoms and he's got a skull fracture, multiple complex skull fracture. So you're going to do a CT, especially in the ER. You could do an MR. It tends to be more non-emergent. You generally will start with a head CT. You want to get a cervical spine as well, and you would do it at the same time as you did the head. And then the other ones kind of follow from there. And as far as radiation, we basically have an idea of what each one of those are relative to the others. What are some of the other findings that you see in child abuse? Especially the ER doc might see if there's any kind of face or mouth injury. That can occur if there was any force feeding, if they have retinal hemorrhages. Subgaleal bleeds are bleeds that are underneath the skin, and you can get that if there's hair pulling or if they pull the braid. Any kind of penile injury can occur if the child has been bedwetting. Hypernatremic dehydration if there's they're not feeding the child properly. And you can get esophageal burns either because the child is force-fed some type of caustic liquid, or if there's some type of neglect and the child manages to get some poison that is somewhere in the house and swallows the poison, they can get really bad esophageal burns. So this child was one of those. It was a terrible neglect. The child went under the sink, saw a bottle of Drano, thought it was water or some other liquid and drank it, and has severe stenosis of the esophagus. This is what retinal hemorrhages would look like. What are some other physical findings that you might see? You're going to look for skin lesions. They get welts if they were attacked with a whip or a belt. You're going to look for burns from cigarettes, radiator, hot plate, or liquid. Any kind of lacerations, if they're whipped, from a buckle, from a bite or a knife, and any kind of ecchymoses if the child does not have some type of a bleeding disorder. Those are some of the things that you would see. If you have a child, we all know that children fall and they scrape their knees, and they lots of, it happens normally. But generally, the bruising areas, again, generally are in the front of the body. They're the knees, the shins, and the elbows. If you see lots of injuries on the back and the buttocks, the back of the thigh and the calves, you want to be suspicious. You want to find out a little bit more of what is going on. This is a child this is hair pulling that caused a very large laceration in his skull. Sometimes you want to look at the shape of the bruising because it may resemble the instrument that is used to cause the harm. This is a child who was whipped. And this was another example of whipping. This was a child when I was a resident. I saw this child. They can get horrible burns if their hand is placed over some type of a fire or some type of something that causes a terrible burn. This was another child that we saw when I was a resident. This child was submerged in burning hot bath and had just horrible, horrible burns. These are cigarette burns. In radiology, there's always a differential, right? There's a differential diagnosis for everything, and there's one for non-accidental injury as well. It could be accidental injury. There is that kind of case. You could have normal periostosis of infancy, where they get periosteal reaction. Osteogenesis imperfecta, they present with multiple fractures And they can, different ages, they could keep coming back to the ER. You want to know the history. If you see that history, it will make you, won't make you jump on non-accidental trauma. Congenital insensitivity to pain. If they often will present with burns on their hands and feet or fractures because they don't feel it. Infantile cortical hyperestosis is a very rare condition where they get significant periosteal reaction and callus all along their extremities. And it could really look like the child had old fractures. Menkes kinky hair syndrome, I'll show you an example. Metaphyseal dysplasia, maybe the metaphyses look abnormal. You want to look very carefully, make sure they are normal looking metaphyses. And scurvy and syphilis can definitely affect your metaphyses and can fool you. This kid has multiple posterior rib fractures, multiple, very clearly seen, a clavicle fracture. This kid was newborn, just born. And it was such a difficult birth that they actually fractured the posterior ribs in the process and the clavicle. If this kid was a couple of months old, had gone home and came back, you would call this child abuse. So history is, again, extremely important. This is a child with osteogenesis imperfecta who had a fracture that's in the process of healing. This is Menkes disease or kinky hair syndrome. They get these femoral and tibial spurs, these little spurs that come off. And if you looked at it, you know, if you looked a little, you might think that these were little corner fractures. They also get retinal hemorrhages, which can throw you off. They often present with seizures, neurologic decline, and they get this kinky, wiry, silvery hair, which is why they get the name kinky hair syndrome. This is metaphyseal dysplasia. You could see right off the bat that the metaphyses look very odd, but you know, this could have been an old corner fracture, and this one as well. So again, you really want to know the history before you jump on non-accidental trauma. And I just want to close with a quote from Nelson Mandela, who said, "There can be no keener revelation of a society's soul than the way in which it treats its children." As radiologists, we can play a very important role in identifying non-accidental trauma in children. I believe, and I think we all believe, that we have been given the gift of knowledge and a keen eye. So let's use them to make the world a better place for children. Thank you.
I forgot to unmute myself. Thank you very much, Dr. Orentlicher.
You're welcome. You're welcome.
It was very detailed. Now we're going to ask the questions. The first one is coming from Dr. Menero Crespo. The question was asked when you were presenting the large bone fractures. So Dr. Menero wanted to know, do you recommend comparative projections of bone in those kind of cases of large bone fractures?
So if there's any suspicion of, in other words, to help you to determine whether it's normal or not, would you get the comparative other side? I would say absolutely. To this day, I still use comparative projections. If there's something that really I'm not 100% sure if it's abnormal or not, I would absolutely get the other side. I find it very comforting if I see it on the other side. And you don't want to accuse anybody of child abuse if it's not real. So you want to be absolutely certain. So do whatever you can to make sure that it is truly a non-accidental trauma.
Okay, thank you. So the second question is from Dr. Rodriguez. She said the ACR recommends CT in children under 2 years old with cranial trauma, even without neurologic symptoms. Some people disagree and should like to know your option regarding choosing between X-ray and CT.
I personally would go with the CT. I find skull X-rays are limiting. And the child it has to be done well. The child often moves around. I find personally that it's maybe because I'm living in the age of CT, which gives so much more information. If there is a suspicion of child abuse, I would get a CAT scan just to be absolutely sure. I don't want to miss a subtle. I have seen many small little skull fractures that I think would have been missed on an X-ray.
Thank you. So next question from Dr. Menero. Do you use fast sonography in abdominal trauma?
With the radiologists, no, we don't. You know, some ER docs have been prone to do their own sonography in the ER just to look for basic things. But no, when it comes to abdominal trauma, we generally will go to a CT or an MR. Yeah. Again, it could be limiting in children, especially small children, and it's worth the. I think it's worth the radiation because you don't want to miss any subtleties at all.
So the last question as well is related to the same thing. It was asked by Dr. Orentlicher. Wouldn't you do ultrasound imaging for suspected abdominal trauma?
You know, again, I think in some institutions they might do it. We're a very large institution with lots of different hospitals. You know, the way I do ultrasound in peds is me personally. I like to go in and I like to look at it myself. But when it happens in the middle of the night and it's done by a technician at one of the satellite hospitals, you know, I would want to get there and look at it myself because I think fractures, liver fractures, things like that, I think lacerations, small things can be missed. And I feel much better if I could see it on a CT scan, especially if I'm not there to look at it myself.
All right, thank you. If anyone among the attendees have any additional question, you can put it in the Q&A box. We had many thank you in the chat box from Mexico, from the Philippines. We have greetings from, I'm checking the countries.
Oh, that's, you know, I have to tell you, this is such a wonderful, wonderful resource that and I feel, honestly, I feel so grateful to be part of this. I think it's just fantastic. So anytime, I'd be happy to help you. And I'm so glad that you enjoyed the lecture, and I hope it helps you spot non-accidental trauma in the future. Thank you.
Thank you very much. So we are just going to wait a few minutes, or if we have any additional questions. If not, we are going to end the webinar.
Okay.
So we have congratulations, excellent information, again from Dr. Menero.
Thank you. Please, if anyone has any questions, feel free to email me. I'll be happy to answer any questions you have.
Thank you very much, Dr. Orentlicher.
Thank you. Bye.
All right. Okay. So that's it. Thank you for what you have shared with us today. It was an excellent presentation. And for all the attendees, we thank you as well for joining us today. We hope that you appreciated the webinar. Thank you very much.
Thank you.